Benzos is where we left off. You don't need to even be watching this one, right? Everyone knows what happens with this. We use them regularly for treatment in the emergency department. Respiratory depression, ataxia. If you give too much, they get hypotensive. If they're around it too long, they'll get hypothermic and then get a coma. Treatment is supportive, let it wear off. Why don't you give flumazenil to benzo overdoses? And the answer is the benzo overdose isn't a threat, but acute benzo withdrawal is. So forcing someone from a non-life-threatening overdose to a life-threatening withdrawal syndrome is generally a bad idea. Some people say you might do it if you sort of knew the person wasn't a chronic benzo abuser. You know, you had a child that ate a few pills. You might use it in situations like that. But understand the concept that in someone you don't know who might be chronically addicted to benzos, reversing them might produce a world of hurt. Beta blockers. Hypotension, bradycardia, AV block, no big deal. All the things you'd think would happen if you block the beta receptors. Antidotes, glucagon, 5 to 10. That's a lot, right? And a lot of times when we're using glucagon, we're using 1 to 2 milligrams. These are big doses. I always pre-treat them with some Zofran or something because you know they're going to puke when you give them that much glucagon. Insulin and dextrose, and then you may mobilize further and go to intralipid. Other treatments, the atropine, the vasopressors, the pacemaker, they don't work that well when you're giving them to a beta blocker overdose. Remember that the eye drops, when you see someone bradycardic, new CHF, they're an older person, they've been to the eye doctor. Timolol eye drops, which are beta blockers because they decrease the secretion of aqueous humor, well documented to cause systemic side effects, bradycardia, hypotension, blocks. So be aware of those. Calcium channel blockers, we're in the C's. These are the most lethal overdoses. When you look at poison center data, calcium channel blockers are the most lethal of all the overdoses. They're often pediatric cases. Both beta blockers and calcium channel blockers are really rough to deal with in a kid. There are situations in which in anyone who's got an overdose on these, where you might even consider, heroic things like ECMO, if you could get it on it, get their extracorporeal circulation going. But the medical antidotes, again, similar, calcium gluconate, glucagon, again, you're talking 5 to 10, insulin and glucose, intralipid, and same sort of stuff. Leading cause of death, mostly peds. And again, it doesn't matter how good a toxicologist you are, oftentimes too much of the drug is absorbed and there's not much you can do. Why would ECMO work? Because you're going to provide them with, another circulation until they have time to metabolize the drug off. And so I have seen that done, but it's not done often, obviously. Carbon monoxide often mimics the flu, right? You see these kinds of cases. And you know how this is, maybe from when you were a resident, but a lot of times you go and you get the second story. I had a resident come out during flu season just this year, tell me patient's got the flu. And I went in to talk to her, and I wasn't even sure why I really asked this. But I said, anything unusual? And that was when she said, oh yeah, my fire alarm went off at my house today. I was like, oh? Turns out it wasn't off for fire, it was CO. And she had levels. So carboxyhemoglobin has high affinity, right? So it shifts the oxyhemoglobin dissociation curve to the left. Everything that's normal and physiologic shifts the hemoglobin curve to the right, right? You get acidotic because you're running. You get, you have increased temperature. So it's physiologically adaptive to shift to the right. Carboxyhemoglobin shifts it to the left, the wrong way. It's colorless, it's odorless, it's sneaky. Alarms are important, as I noted in the case I just described. Sources, incomplete combustion of any fuel, charcoal, kerosene, wood, gas. Scenarios, anyone pulls the grill inside and cooks there because it's raining or nasty out. So that's one way. Bad heaters, old heaters. Long drive in a car with a bad exhaust system can sometimes do it. You'll hear stories like that. Carbon monoxide is one of the more ways commonly to die. And I told you earlier that most of the people who arrive at the hospital don't die. They arrive alive. Carbon monoxide patients who die are found dead. So it's not that you can't kill yourself from an overdose. Though the people who have successful suicides and other things like that who die of overdoses are found dead. Of those that arrive alive to the emergency room, very few are going to die. Headache, nausea, confusion, very non-specific symptoms. If you're expecting to see cyanosis, don't. This is where the famous question, is your dog sick? Right? You see in a family, 3 of them, you find out the kids are over in the peds ER, and then you ask the question, is your dog sick? If the dog's sick, it's not the flu. Dogs and humans get different respiratory illnesses. In general, there are some that overlap, but generally not. Toxicity, there are multiple sites of toxicity for carbon monoxide. It's not everything that happens at the, for example, at the hemoglobin level. There's also intracellular targets. Organs with high oxygen demand are going to be the first affected, so you should get an EKG looking for ischemia. You should see what their mental status and neuro exam is, because those are going to be the first. Severe toxicity is altered mental status, chest pain, EKG changes, and they get cardiogenic shock, because not only does the heart get enough oxygen, it doesn't, but it also has myocyte intracellular toxicity, which causes the cardiogenic shock. And so you want to look for that. Now, when you're dealing with fires, there are often questions that are written by people who make exams. A fireman collapses at the scene. That is not carbon monoxide. That's cyanide. Someone who, after being at a fire or around this, has symptoms, then you're talking carbon monoxide. Crosses the placenta, has an even higher affinity to fetal hemoglobin, which is why you would have a lower threshold for treatment if the patient is pregnant. Half-life, they do sometimes, if they're in a nasty mood on exams, ask these: 5 hours room air, 1.5 hours on 100% O2, 20 minutes on hyperbaric oxygen at 1.5 to 3 atmospheres, depending on what they're doing. Delayed neuropsychiatric syndrome. It's, when you talk about this, one of the proposed things that would be a benefit of treating someone with this is there is this delayed onset sort of neuropsychiatric syndrome, and it's thought that hyperbaric oxygen, while controversial, might do this. I don't think hyperbaric oxygen is coming off as the answer, even though this has been debated widely. I was even involved in an ACEP debate, and Jerry Hoffman was there, and some of the pro-hyperbaric people, it was just a mess. It was a shit show. But anyway, there are still people who believe very strongly in hyperbaric treatment, and there are people who believe it doesn't really work. Carboxyhemoglobin, the pulse ox will be normal. The PaO2 on the ABG is normal. So you need to actually measure carboxyhemoglobin levels. That's important. All right, now we're on to caustics. Acids and alkali, and so you have to know the underlying labels there. Alkali is worse because it causes liquefaction necrosis that keeps on progressing, as opposed to acids, which cause coagulation necrosis and eschar. Now, when you're looking at someone who did something with the Drano or something like that, what you see in their mouth, and this is very true in peds, doesn't really tell you what's going on. You can picture a child, for example, getting some of this stuff in the mouth and kind of not swallowing any of it, spitting it out, with a bad oral pharyngeal burn and no esophageal burn, because it just kind of rolled out in the mouth and came out as drool, nothing swallowed. And you could also picture somebody kind of throwing it back like you would a shot glass, not much in the mouth, and bad esophageal burns. So what you find in the mouth doesn't tell you whether or not there's an esophageal injury. Your concern should be that they're going to need esophagoscopy to see what it is, all right? Caustic injuries, no charcoal. Don't lavage it. Hydrofluoric acid ingestions, rare question. Most of the hydrofluoric acid questions on the exam are about cutaneous exposures, wink, rust removal. But if a kid drinks it, you can give milk or mag citrate, and that might work. Solid alkali ingestion, like Drano crystals, you can dilute those with milk or water. Other caustic ingestions, dilution is contraindicated because they might vomit, and you don't want to bring the caustic agent back up top. And then urgent endoscopy, again, regardless of what you see in the mouth, if the history seems to be confirmed that there was an acid or an alkali ingestion, you need to get them scoped. In real life, probably some of these are going to wait till the morning. GI can come in a couple of hours, kinds of things. But on an exam, it's urgent endoscopy. And this is what you're worried about. That's an esophageal stricture. And that might occur in someone with a pretty normal oropharynx because they threw it back and swallowed it. Chlorine gas. We all know what chlorine smells like. It's widely available. It's a yellow-green gas, pungent odor. What happens is the gas gets into your lungs, and it's an irritant there with pulmonary edema. If you talk to an experienced hazmat person, you know, what are the settings where big hazmat things happen, right? You know, you're talking about a oil refinery blows up or a train crash or things like that. If you talk to people who really know that world, they'll tell you the most important piece of equipment they need is 10 by 50 binoculars, because that's close enough. If you ask them the next piece of information they want, it's the prevailing wind direction. Clonidine, we already talked a little bit about it, alpha-adrenergic. Hypotension, bradycardia, can mimic the opiate. They can have lethargy. People will eat the patches. Treatment fluids, atropine, and pressors. Pretty straightforward. Supportive care rules the overdose world. Cyanide, this is the immediate collapse at the fire by cytochromes, causes anaerobic metabolism and severe lactic acidosis. This is another setting, mate, where you might see things like bicarb equals 0. Source, jewelers, chemical labs, apricot pits, remember the Laetrile stuff with the cyanide in it? People going to Mexico, coming back with cyanide poisoning. Abdominal pain, nausea, sudden cardiovascular collapse. Distinctive odor, bitter almonds. We'll have the odor chart for you near the end. That's another little thing I sometimes look at before I take exams because I can't remember them all. They get a lactic acidosis, they get an anion gap, and the treatment is to get rid of the cyanide and get to cyanomethemoglobin. So there's the whole cyanide kit, amyl nitrate, sodium nitrite IV, then sodium thiosulfate, then sodium thiosulfate plus cyanide will give you thiocyanate, which can be excreted by the kidney. The cyano kit, which is the vitamin B12 precursor, hydroxycobalamin, many fire chiefs have lobbied hard to get this. They're expensive, and that's because they want to be able to treat mostly a fireman who collapses on scene. It's not really out there for, you know, widespread thing. And what happens with this is that combines with cyanide to form cyanocobalamin, which is cleared renally. And that's why the fire companies want to have this, is because obviously they're a very high-risk environment for this, and it's to treat them. DIG. I used to love DIG. DIG is kind of a dinosaur looking for a tar pit. There's really no reason to prescribe anyone DIG in, 2018. It's a lousy negative chronotrope. It's a lousy positive inotrope. In the big DIG withdrawal studies that were done in the 80s, you take people off DIG, no one gets worse. It was a drug that produced among the highest number of admissions for complications. If you were to look at old data on which drugs made people have to come back and be hospitalized because of the drug, the answers were Coumadin, DIG, and theophylline. Those were the bad players that got people needing to come back to the hospital. What does it do? It inhibits the sodium-potassium ATPase pump. That's the phrase. They get hyperkalemic, AV blocks, and arrhythmia. The antidote is Digibind with the Fab fragments. 20 vials will cover anything, but if they ask you to calculate how many vials, there are 3 or 4 different formulas. That's a mean question if they ask that kind of thing. You could get the formulas, then use the level, then use their weight, get to an accurate thing. If they do that to you, it's usually 3 to 5 vials. I would just guess whichever one's closest to that and just take my hits because I'm not learning those things. Or as said here, you could just say, I'm going to start with 10 vials and see where that gets me. Obviously, the stuff is really expensive, so that's where this kind of stuff comes in. But there are multiple formulas for calculating it, and we're not going to go into them here. I think those are appropriate questions if you're writing a toxicology exam as opposed to a research exam. Class 1A antiarrhythmics are contraindicated. That implies you know what the Class 1A antiarrhythmics are, and you remember that whole classification system, right? There were the 1As, Bs, and Cs, and then the Class 2, 3, 4s, and the others. But the Class 1As are contraindicated because DIG decreases conduction velocity, and so do they. So that's the quinidine-like drugs. If you want to translate Class 1A, it's quinidine and procaine are Class 1As. All right, low potassium worsens the toxicity. In other words, DIG is a cardiac irritant, and hypokalemia is a cardiac irritant. If you add the two together, you're much more likely to have a dysrhythmia. However, the overdose, because it poisons the sodium-potassium ATPase pump, causes hyperkalemia. And in fact, a K level higher than 5.5 is an indication for digibind. So don't get confused over this high K, low K stuff. The overdose causes high K, but at the time of the overdose, if you have low K, you're more likely to suffer a dysrhythmia. Okay? The pathognomonic, let's go through the arrhythmia stuff that gets asked as questions. Most common PVC, most common EKG change dysrhythmia of DIG. Most common dysrhythmia of DIG, PVCs. Most common EKG change of DIG, Salvador Dali mustache. Most diagnostic EKG change of DIG, PAT with block, is pathognomonic for it. Because DIG increases automaticity, hence the PAT, and decreases conduction velocity, hence the block. Calcium administration is contraindicated. That's been argued. There's something, I don't want to get into it, but that's an ongoing argument, but I think the accepted answer is don't give calcium. So we got the most common dysrhythmia, PVCs, most common EKG change, Salvador Dali, the SDT wave changes, the Salvador Dali mustache. Most pathognomonic but rare dysrhythmia, PAT with block. GHB, naturally occurring analog, started on the West Coast among weightlifters. Why did weightlifters use this stuff? There was some research in grizzly bears who put on 200 pounds where they found that in the brown fat of grizzly bears, this was a key portion of the way they put on weight. So that was all that the weightlifters needed. Me like bear, weight gainer. They're already drinking like the Muscle Milk 5,000, taking all these supplements, and it's test negative, so they wouldn't get disqualified from the things. So the weightlifters, muscle builders, Gold's Gym types started using this as a weight gainer strategy. They found out that if you drink more of this and do more, you get high from it, and so they got onto it. And so it's got these street names like Georgia Homeboy, Grievous Body Harm. It's like you got your B and your H backwards. They're not the smartest. They're not the smartest. Where do these guys work at night? They're bouncers. So they were selling it at the club door. It became a date rape drug thereafter because people get knocked out very quickly with it. And when you like bear, hard to get date. Sometimes need to knock woman out. Yeah. Not routinely detected on drug screens. If it's a legal case, you need to send urine for specific testing. And you know what this is like. For those of you who haven't seen it, I'll explain it to you. They come in. It's not like their breathing slows down. It's not like, boy, I'm going to have to worry about them. They just stop breathing. So they're there in their apartment. They often come in. They're might be a little agitated or something. Everything, you examine them. There's nothing specific in the way of a toxidrome. And then they just stop breathing. So you're an ER doc. You're like, not breathing. I'll breathe for them. So you throw a tube in. You hook them to a vent, and a few hours later, they yank the tube and want to leave. And that's fine, actually, if they want to leave that way. Treatment is airway control, rapid resolution. It lasts longer if they're really drunk at the time they do it. You can mix this easily into drinks. You can still buy it on the web illegally, or its precursors with things like it's I love when you look for it on the web, pina colada flavored cleaning solution. Just in case that's how they mark, to try and make it sound legal, they have it as a cleaning solution. All right, some hallucinogens. LSD, mushrooms, mescaline, morning glory seeds, and morning glory flowers. If you make morning glory, make tea out of it. Again, on the instruction of the vaults of Arrowwood. Some designer drugs, MDMA to a limited degree. They're serotonin antagonism, and they get psychosis, anxiety, tachycardia, hypothermia, dilated pupils, treatment, benzos, maybe a touch of Haldol, depending on how paranoid they've become with it, and go from there. Now we're just chewing this alphabet up, man. After spending a little bit of time on A and B, we're forging ahead. Hydrocarbons. There are a couple questions that come up with hydrocarbons. If they have a toxic thing. It's a hydrocarbon with some toxic thing on it, like lead, then you have to deal with that thing. But halogenated hydrocarbons or other toxic additives increase toxicity. The lower the viscosity and the higher the volatility, the more the problem, because the stuff is, as you're drinking it, it's being breathed in. It causes pulmonary problems. Aspiration pneumonitis is the big deal. So again, the thicker and more sludgy it is, you swallow it, it stays down there, it doesn't get in the lungs. The more volatile it is, the higher the volatility, the lower the viscosity, the more it has a chance to get in the lungs and cause pneumonitis. Sniffing and huffing can sometimes do some of this stuff and sensitize the myocardium. If you ever hear the story, you know, the cops were after some kid who was doing some graffiti, and they chased him, and then he dropped. What he had is a tachydysrhythmia because they get the sensitized myocardium. So it's a 14-year-old who has a sustained run of VTAC. They often come out of it spontaneously. If the cops don't get there quickly, the kid will get up and run again. There's more propellant and hydrocarbons in the gold and silver paint. If you ever wondered why these kids are using it, you see a bunch of graffiti with gold and silver. Those are huffers that are doing that. The gold and silver paint costs more, but it's heavier and it has more of the hydrocarbon propellant. Any kid you see with these gold tips on their hair and their face who's brought to your emergency room after collapse, that's a dysrhythmia. If you're into Audubon and you use your binoculars from a hilltop in Los Angeles looking at the underpasses, you might see the rare silver-headed huffer down by the LA River. You know, spot them, soon to be running from the cops. Lavage them if it's halogenated, carbon tet, things like that. Chest x-ray can be often, as with a lot of tox problems, can be initially normal, and they may have delayed findings with the pneumonitis. Steroids and prophylactic antibiotics sound like a reasonable thing to do, but have never been shown to work and are not indicated. The general rule is not to empty the stomach. Why? You don't want the stuff in the lungs. This is all about the lungs. Don't get the stuff in the lung. The toxic substance mnemonic is here for you. Camphor, halogenated aromatic metals, and pesticides. Those are when you need to get involved because now you're treating not just the hydrocarbon ingestion, but the toxic component associated with it. Hydrogen fluoride, we touched on it. If the question mentions anything about rust remover or glass etching, there are certain clues in questions, if you've seen and taken these types of exams, that people who write questions put in, and they're buzzwords. So glass etching and rust remover means hydrogen fluoride. If they say things like woodpile and attic, that means loxosceles spider. There are just certain code words that go with certain things. The code word here is glass etching and rust remover. And they were not using the yellow gloves that they says to use, and so they have finger burning. The skin might appear normal, and they're howling. You might think, what's that? There's nothing wrong with your fingers. And what it is the fluoride ions are burning their way through their skin and into their tissues. They keep penetrating until they're quenched. I like that term. And how do you quench a fluoride minus? You quench it with calcium. So it's going to burn to bone until it forms calcium fluoride. And so you got to stop that. And the treatment, therefore, is calcium gluconate, and you can do local infiltration if it's just a fingertip. We used to take the calcium gluconate powder, not the stuff off your crash carts or in your nursing, and then mix it with petroleum jelly. The powder works a lot better than the liquid calcium gluconate. Smear it all over the hands and then put gloves on them, regular old medical gloves, and see if their pain resolves. If their pain resolves, the burning has stopped. That's one of the key measures. And that's another reason why you don't want to do a digital block on them, because then you don't know if the pain's resolving. You need to know if the pain's resolving, because if the glove and the smeared-on topical jelly doesn't get it, then you need to up the ante. And what's the next step if topical doesn't work? The next step is local injections and infusions around the area. And the next step is to do what's called like a beer block, where a BIER block, where you put up a cuff and fill the extremity with calcium gluconate and see if that stops it. And finally, the last step is to try intraarterial injections with calcium gluconate. Okay? Hydrogen sulfide, the rotten egg smell, oil refineries, hot asphalt, sewage, mines. It's an asphyxiant. And so you need to remember that. So what's the problem with someone who dies of asphyxiation from this? If you show up on the scene and run in to get them, what's going to happen to you? You are going to asphyxiate. So that happens, it depends on where it happens, but it might happen 3 times. Bob goes down and then, another person runs in and they go down and the third person still doesn't get it. And so, you got to get rid of it before you go in there because it's an asphyxiant. It inhibits cellular respiration, blocks cytochrome oxidase, and smells like rotten eggs. This is the classic story, the manure pit at the end of the barn when they have automated. I grew up in the days where you had to shovel the shit. But they have now these automated things that pull the shit out to this huge basin. Someone gets down there, they're cleaning it out, and then they go down, they're asphyxiated by the manure that's left in the container. And it's a gas that's a little heavier, so it will displace all the regular air out from the container. So a sewage tank, a manure pit, so that will just be filled. So if you get into it, there's no air in there. And so you get asphyxiated. Higher affinity for methemoglobin than cytochrome oxidase. Treatment is removed from the source. And I would add right after that, try not to die yourself while removing them from the source. 100% oxygen, and then you can give them some methylene blue if you have it handy to treat them. And they always go for this discolored copper coins in the pocket, and they sometimes talk about the brown blood, and that's hydrogen sulfide. Isoniazid, this is a favorite one. This is another code word. And please, I am not the one who picks the code words. I just report the code words. If they say Vietnamese grandmother anywhere in the story, then it's isoniazid. I don't know what the Vietnamese did to earn this. Certainly it's not the only place in the world that there's tuberculosis, but if they mentioned Vietnamese, then it's isoniazid. And the kid gets into somebody's isoniazid, what happens to them is they get status epilepticus, and you can't stop their seizures. You give them benzos, you're on like the second stuff, you're doing other things. And what do you do there? You give them pyridoxine is the antidote, and it's gram for gram. If the kid took a gram of isoniazid, they get a gram of pyridoxine. As you can imagine, most of these are pediatric cases, so who knows how much the kid got. If you don't know, you give 5 grams of pyridoxine as a starting dose. One of the things that cracks me up about ordering vitamins in the emergency room, whether it's thiamine or pyridoxine, whenever you order it, the nurses act like you've ordered plutonium. It's like there's like some act of vitamin restriction when you want to give these vitamins. They're like, sign here, sign there. Sign. Can we have your, we need some backup funds or something to cover the vitamin that you want to give. I always laugh by that. Like for example, if someone has Wernicke's, I will often give gram amounts of thiamine. When you ask for that, they look at you like you're some criminal. Yeah. All that B1, woo! Selling it on the black market, yeah, taking some out of here. Meanwhile, I also remember the days when we used to use the cocaine in solution, the 10% solution for the nosebleeds. No one tracked that shit. Suddenly, the hobby shop is out of the chemistry set, so you could lyophilize it back to powder. All right, now we're on to iron. Common cause of poisoning. What's the story here? That if they, sometimes when we give oral exams at LA County, one of the stories and Diane already mentioned, you have the dad at the bedside holding the new baby, seizing mom, think eclampsia. You have the mom there with the 2-year-old kid with the sick new baby, think iron, right? She was taking them for her pregnancy, the kid overdoses, and now the kid's sick. So it's a new or a pregnant mom with a sick kid, the older kid. This is the one who got into it, right? The toddler is the one that went around and snarfed up all the pregnancy vitamins and is now sick. Again, remember we talked about acetaminophen had this sort of silent period and why I want the level? Because it's everywhere and it's lethal and it's treatable. Iron is a little bit like that. It has a silent phase. Notice the 6 to 48 hours quiescent phase. So a kid comes into your emergency room a little irritable, cranky, with some gastroenteritis. I'm pretty sure I'm sending that shit home. Right? Let's tell the truth. When you hear about someone missed an iron overdose, so some kid came in with a little nausea, vomiting, and diarrhea, I'm like, I'm missing it. I mean, how would I supposed to know? So these are tricky, and this is where you start getting after other levels that might help you. 12 to 48 hours, they get sicker. And the other things to know about iron overdoses is, do we have it here? So you want to get a 4-hour level. Where's the things I'm looking for? They get a high white count, and they often get a little bit of a high sugar, too, with these. So you got to look for that. Lab suggestive, increased gap. There it is, increased glucose, increased white count. See, circle that increased glucose and white count. I remember the old days in the poison center where we used to look for that. Specifically, if they've got a white count greater than 15 and a glucose greater than 250, you know that this is going to be bad and start getting ready to treat them. Liver has the greatest injury because of the portal circulation. You want to get an abdominal series with a chest x-ray looking for a Bezor, right, a clump of iron pills, the iron vitamin tablets. And the antidote is defuroxime for the chelating agent and whole bowel irrigation until the radio-opaque tablets are gone from the GI tract. Now, defuroxime, you can give it IM or IV. What are the indications for giving it IV? They're severe acidosis and shock are the indications for it IV. What's the problem with that? The complications of giving it IV are shock. So the indication for the IV def is shock, and the problem with giving IV def is shock. I think that makes it clear that this is a little bit of a dicey situation if you see a kid dying of an iron overdose, because you're going to have some, it's going to be a bit of a rocky road, and you really should be looking for peds critical care help on these without a doubt. I've managed a couple of these, and they can get tricky as hell. What happens if you give an iron, the defuroxime IM, and a not-so-sick a kid? What are you expecting to see in like 15 minutes? Pink urine, the Vin Rose urine should come out. That's called and if you give a challenge dose, and let's say it, let's get it out. So that's called a defuroxime challenge, looking for the Vin Rose urine. Most challenged, there's a bunch of challenges out there for some of these metals, and most of them are not believed to be accurate enough to be used. But occasionally there are still questions on the Vin Rose urine. There it is right there. The first tube on the left, they just gave the IM shot. They waited a little bit, and the urine gets more and more. And that means that it's chelating iron out, and that's what it looks like when iron is chelated to defuroxime and in the urine. All right, lead. Used to be a common cause of chronic poisoning, right? We all know that lead paints have been removed, and if you have lead paints, you got to get them out of there. And it was often seen in kids who had pica, and they get headache, encephalopathy, abdominal pain. They might get lead lines on their bones. The toxicity is CNS, GI, and hematologic. The classic clinical finding is a wrist drop, a peripheral neuropathy with lead. And the diagnosis, serum levels greater than 50. Basophilic stippling, they still love that. Basophilic stippling is a sign of lead poisoning. Treatment is chelation with the agents as shown at the bottom. If you see a GI tract full of lead, like this one on the left, that's whole bowel irrigation till all those paint flecks are out of that kid's stomach, out of that kid's intestines. In this case, it's large intestines. That all needs to go because they're still absorbing it. And then you see the x-ray with the lead lines on the bones. See how dense the end plates are? That's because there's lead deposited there. All right, lithium. I love the fact that we have drugs that we're going to use to treat crazy people who are prone to overdose, and those drugs, some of them are lethal. So having a lithium overdose, like who wants to give a manic person a drug that will kill them if they overdose on it? And same with tricyclics. Remember the old days? A lot of you in here remember the days of wrestling with these bad tricyclic overdoses. Fortunately, they're largely gone. I haven't seen a bad one in, years. But I can remember, 25 years ago when we used to see these all the time, you'd be wrestling with them. But lithium is still, it's effective still for mania and manic depressive treatment. It's eliminated by the kidneys. You get hyponatremia and hypovolemia, which increase toxicity, so you want to give normal saline to them to help treat it. Toxicity can be delayed, and chronic toxicity is really tricky. The blood levels are only useful in acute overdoses. They're really not useful in the chronic overdoses. Clinical is tremor, vomiting, diarrhea, confusion. They may get seizures as well, tremor, seizures, and the fasciculation kind of thing. You can see all of that with this. GI symptoms happen early and are common. I love that sentence down the bottom, like that's helpful. That's not helpful. It doesn't help me at all, unless they tell me that they're, because sometimes they don't tell you. Let's talk a little bit about history. I haven't talked about this in tox patients. So, in overdose patients who are awake enough to talk to you, what do they tell you? Do they tell you the truth? So no, about half the time they tell the truth and about half the time they lie. So it's like a 50-50. But it's okay, you're an ER doc, you're cross-referencing, you're asking the paramedics, anyone at home, who knows the bottles, what do we got? You're checking their recent prescriptions. We all know how to do that. Now the problem when they lie is they lie in both directions. Sometimes they overstate what they took. I took 150 tablets of this, and then nothing happens, and they clearly didn't. And they understate what they took. They omit the 10 grams of Tylenol, which is asymptomatic. So you got to be careful they lie in both directions. You always want to cross-reference the story. You want to be cautious with these. But GI symptoms are so nonspecific, I find it to be very unhelpful unless someone told me that they took lithium and I believe them, which is already a bit of a stretch of imagination. Lithium EKG changes, they love this question. Bradycardia, QT prolongation, they love. And you may see some T-wave changes in inversion. Clinical status more important than the level. Why? Because most of them are chronic or acute on chronic. Normal saline challenges, hemodialysis if they're looking sick. Dialyze based on clinical indications. What are those? Coma, seizures, myoclonus, those types of things. If the level's greater than 3.5, it says on the slide here, that's high for an acute overdose. They're gonna get sick. They should be sick right now when you get that level back. But if you see levels like that in an acute overdose, that's bad. That's bad. Call for dialysis and get ready for things like seizures, because that's what's going to happen. All right, monoamine oxidase inhibitors, fortunately, largely gone from the scene. They're still around for some weird indications, and sometimes they're out there. They block degradation of catecholamines, norepi, epi, and serotonin. Their symptoms are delayed, but they're headache, hypertension, tachycardia. You know that you can't give them Demerol or dextromethorphan because they're going to get the hypertensive crisis, the whole Libby Zion thing, which anyone who's read about the Libby Zion thing knows it was a lot more complicated than that. But there you go. Those things are linked together. Other things that cause a hypertensive crisis, amphetamine, cheese, wine. That sounds like a good night so far. I don't know what the hell you'd be doing with the fava beans. If you eat fava beans, you get what you deserve. Some chef downstairs just cringed who thinks they're doing something innovative with fava beans where they could have substituted sawdust. All right, methemoglobinemia. We encounter just a kid with diarrhea, I'll tell you, a kid with bad diarrhea and volume contraction. Probably one of the most common causes of methemoglobinemia out there. It's just a normal factor of their metabolism. So young kids who are volume contracted will get a little methemoglobinemia. But how do you get it in general? It's reduction, results from the oxidation of normal iron in the Fe2 to the 3+ state. Methemoglobinemia can't bind oxygen. The causes are the nitrates, the nitrites, the benzocaine. Have you ever seen someone turn blue when you were spraying their throat with the hurricane spray? That's this. That means you were a little too aggressive with the hurricane spray. You might want to back off. It happens, though. We've had cases up in the unit where ENT was trying to do something with a scope, and the second-year resident was struggling, and so the third year shows up and says, let me give it a whirl. And they go, it still won't work. Then the senior comes down, you idiots, give me that. And then the person turns blue after like the fourth round of the benzocaine spray. It's like, yeah, it's not working so good. If the question says anything about home smoked meat, that's the nitrites and the nitrates is what they're after there. May have vague symptoms, etc. Cyanosis is unresponsive to oxygen. It's not the only thing that's unresponsive to oxygen. It's one of the key things. I had a guy, I'll never forget this case. So my shift was ending at like 1. I got this guy who comes in cyanotic with chest pain. I'm asking him all kinds of questions. I've got him on oxygen. I'm doing stuff, the EKG. I don't know what the hell's going on with him, but the guy's blue. He looks like a Smurf. I can't figure it out. Finally, his friend comes in. I love it when the friend comes in. The friend's at the bedside. Did you tell him? I'm like, yeah. Now would be a good time. Please tell. So what he'd been doing is hooking a 9-volt battery, one of those big square batteries, to silver to oxidize, to put it into solution, and then he was drinking it because he went to some all-naturopath healer who told him gold is for, rheumatoid disease. Silver is for lupus. He thought he had lupus. He didn't have lupus. But anyway, so he'd been drinking this silver solution, and then once I knew what it was, I looked it up, and it causes esophageal erosion. So he had the esophagitis, and that was his chest pain, and it's one of those things. When you're learning on the job, where you write on the chart because you've never written it before on a chart. Argyria, I wrote on the chart, and I was like, I thought that was a terrorist sponsoring state. But no, that's, Argyria is the silver poisoning. But methemoglobinemia is that's one form of cyanosis that won't get better because the silver deposits in the skin and then it develops in the Southern California sunlight, so your skin's going to be gray forever, gray-blue forever. Methemoglobinemia doesn't respond to oxygen. They get the chocolate brown blood. I already mentioned this is seen with self-hemoglobinemia already. And the cyanosis reverses with methylene blue. So while it's not responsive to oxygen, it is responsive to methylene blue. Mushrooms. I can remember collecting morels as a kid in the Berkshires. It was like gold. It was big money. You learn things when you're doing things like that. And the line that they're told, the sort of country wisdom, is there are bold mushroom eaters and there are old mushroom eaters, but there are no old, bold mushroom eaters. So if you don't know what it is, don't eat it. You need to be really sure. So the most lethal of all the mushrooms are the amanita. Not all the amanita kill you, but if the name of the mushroom is the death cap, seems reasonable. Now, the key thing on the questions for the mushrooms is how long it took between when you ate them to get the diarrhea, nausea, and vomiting. So if you ate the mushrooms at dinner and you're puking and shitting before bed, that's good. You're going to live. That's not a serious mushroom. You're not going to do it again, but you're not going to die. But if you eat them at dinner and go to bed and you wake up the next day and start feeling a little bad, delay, now you're in trouble. Symptoms within 2 hours, benign course. Symptoms delayed greater than 6 hours, uh-oh. So, like I said, it's called the death cap. Now, the problem with the death cap, Amanita phalloides, is it looks just like the white mushrooms you buy in the store, right? If you were starving, I'd eat that if I was starving. Nausea, vomiting, diarrhea, 12 hours post. The toxin kills your GI cells and your liver. Treatment, supportive care, and liver transplant. You never want to have a disease where the treatment ends with liver transplant, because there aren't enough livers to go around. It might as well say, and death. Now this one, I'm sorry. Look at that. If you eat that, what can you say? I don't think you have to be a genius to know. I don't know, it looks like, looks bad. I don't think we should eat that. Anyone with an ounce of common sense, like you could be from another planet. When you stumble upon a rattlesnake and it's there with the head back on, you have to be an idiot to think anything other than take a step backwards, Bob. I think if you eat that, you deserve what you get. Look at that picture of them. You got to know not to eat that. It was funny. I did a talk once on the fish toxins, all the things, scombroid and all that, and of course I did the fugu, and so I was looking up the names for the fish in different countries for the fugu poisoning, and in every country you did not have to speak the language to know that you don't eat that. Like I remember that the name for it along the Red Sea in countries like Egypt and places like fahaka. Like, I don't need to know what it is. You pull something out of the water and all the locals point at it and say, fahaka! No, you don't eat that. That mushroom right there is saying, fahaka! Don't eat it. All right, psilocybin down at the bottom, hallucinations, euphoria, nausea, also known as an evening in Amsterdam, supportive care. All right, neuroleptic and phenothiazines, clinical effects, dystonia, tremor, torticollis, that doesn't sound fun. Akathisia, we've all seen that, right? You gave someone some compazine, the next thing you know, they've ripped out their IVs, you're like, hey, what's happening? I thought we had a plan. I gotta go. That's what they always say, right, isn't it? I gotta go. You're like, where are you going? If you could find out what that receptor is and make a drug for I gotta go, imagine how rich you would be. You'd be in the emergency room with that person you can't get placed, that could go home. You'd be like, give him 5 milligrams, so I got to go. No, no. You'd look at the nurse, give him 10. Yeah. You've all seen that. They have some quinidine-like things, so they can get some QT problems, prolonged QT. And they can also put you at risk for heat stroke, right? You don't sweat when you're on neuroleptics and phenothiazines. The treatment is cogentin and benzodiazepines, and you might give them Benadryl too. I had a patient recently on Zoloft. Anyway, she came in, we thought it was a stroke. She'd had previous aneurysm clips, and she came in saying, I can't talk, I have this speech problem. The residents went in, they didn't, at Stony Brook we have the code BAT. You all got your, if you work at a stroke, brain attack. Anyway, she had the code BAT going on, and we did all the things, and I kind of knew something wasn't right. Anyway, the whole workup was negative. And so we're getting ready to let her go, saying, I don't know. Anyway, I went in and talked to her some more, and that was when she said, it feels like my tongue is pressed up against the roof of my mouth, like I can't let it go. And the husband was there, and this was the first I got this history. He goes, I'm rubbing this side of her neck and into her, and I was like, and I went through her meds again. I was like, there's nothing there. This is Zoloft. I was like, have you gotten a shot of Haldol? I was looking. And then I was like, just the Zoloft. So then I just looked it up, Zoloft. And it causes jaw dystonia specifically. I was like, there you go. So if you see that, you heard it here first. Neuroleptic malignant syndrome is rare. It's not dose-related. It's slower in onset. Leads to lead pipe rigidity. This comes up as on the exams as well. Treatment, dantrolene or bromocriptine. You don't call those out often. Look at that bottom of that slide. Naloxone, dose 0.2 to 2. We've talked about this. The half-life is less than some long-acting opiates. Continuous drip may be required. Sometimes they ask about how do you make the drip, so let's just do that real quick. Let's say you gave 0.4 of Narcan, 0.4 of Narcan, they still weren't awake, 0.4 of Narcan, they still weren't awake, you gave another 0.4, so the total is 1.6, 4 0.4s. And they woke up a little bit. So you give them 1.6 and they reversed. And then a half an hour later, they go down. The drip is half and half. You would bolus them with half the reversal total and drip them at half the reversal total an hour. So 1.6 was the reversal total. They start going down again. They get a bolus of 0.8 and a drip at 0.8 an hour. Oral hypoglycemic agents. This is still going on. There are lots of them out there. There's a list of them. Increased release of insulin from pancreatic cells. They get prolonged hypoglycemia, and so they often need to be admitted. If the question asks about it, they need to be admitted. Non-sulfonylureas do not cause hypoglycemia. Now, metformin, which doesn't cause hypoglycemia, can cause lactic acidosis, and fenformin, if you're seeing people who are going across the border for treatment, you'll see sometimes fenformin doing that as well. Treatment, glucose bolus and drip, glucagon, and then octreotide. If they are refractory or recurrent hypoglycemia, octreotide is the answer. That's got new popularity on exams. Some poisonous plants, the pits of apricot, we're back to Laetrile. All the stone fruit pits contain cyanide. Anticholinergic plants, deadly nightshade. They're bright red berries. They look like they should be delicious. They're not good. Henbane, Jimson weed, we already talked about. And the digitalis-containing plants, foxglove, oleander, lily of the valley. Everyone has these stories. I actually saw it one day. I was at LA County where the Boy Scout troop took the oleander plants, stripped the leaves off, put the hot dogs on, put them in the fire. The hot dog sucks up all of the products from the plant, and then the kids all come in blurry vision and bradycardic. There's the cyanide, the stone fruit. There's the Jimson weed. That's the Datura species. Some people call it dragon plant. There's foxglove-containing plants, the foxglove on the left and the oleander on the right. Tobacco, pediatric ingestions of cigarettes. I remember the first time I tried chewing tobacco, I was like, oh my God, it was terrible. I had all these cholinergic symptoms, salivation, nausea, vomiting, diarrhea. It was terrible. Lavage, charcoal, benzodiazepines. Rodenticides, warfarin and superwarfarin, which is rat poison. Duration can be as long as 6 to 8 weeks. A lot of these, shockingly, are managed as outpatients. You're going to give them vitamin K to treat them, and if they're bleeding, they get FFK or PCC. You want to give the 4-factor if you can. Salicylates, we already talked a little bit about this. uncouple oxidative phosphorylation, so they get tachycardic. The acute poisoning, they might see some GI levels. Chronic poisoning, more CNS, often elderly. I remember I saw this patient with a resident, this is several years back, and I go there, the patient's got a temp of 101, she's a 70-year-old lady, she's sort of agitated in the room but somnolent. The resident tells me the chest x-ray is negative, the urine's negative. Do I have to LP her for her fever workup? And I kind of look in the room and I recognize it because I've seen it before, and I go in there and I hold her shoulders. Ma'am, I say, ma'am, what are you hearing? And she looks at me kind of shaking her head and looks at me and goes, fucking my egg! And we said to the resident, maybe we should get an aspirin level. And so you'll see that kind of pattern. It's an agitated somnolence with an anion gap metabolic acidosis, right, because of the uncoupling, and a respiratory alkalosis with the tachypnea. They may get hypoglycemic. They can get a non-cardiogenic pulmonary edema, with this patient that we were seeing didn't have. And the nomogram is not recommended anymore. Again, the levels can mislead you. If you see a nursing home patient that smells like wintergreen, that's from oil of wintergreen. We had one just the other day at Stony Brook that was salicylate toxic. Remember, oil of wintergreen has very potent for salicylates, and they can have transcutaneous absorption of it. All right, now we're on to serotonin syndrome, with the drugs that you see there, all used quite a bit now. And these selective serotonin reuptake inhibitors, when you get this, they also can get some rigidity, but it's more rapid onset as opposed to neuroleptic malignant syndrome, which is slower. It's lower extremity more than upper extremity, as opposed to the other one, which is the whole body lead pipe. Okay? Tricyclics, again, not seen as often anymore. They have some anticholinergic effects, some CNS effects, and some cardiovascular effects. We all learned how to identify the EKG. It's a favorite type of question to ask, the EKG. Remember what the EKG shows. It's QRS widening with an R wave and AVR. There was the famous paper from Diane's place by Neiman that had this phrase in it. What are you looking for on the EKG? And Neiman wrote, a counterclockwise rotation of the terminal 40 milliseconds in the frontal plane, for which most average readers went, what him say? And what him say is, look for an R wave in AVR. Treatment, lavage, multidose charcoal, and anytime a TCA patient does anything you don't like, they get hypotensive, they get dysrhythmia, they get widening QRS, they look like they might seize. If they do anything you don't like, they get 2 amps of bicarb. Hi, how are you? Slam, slam. When they get seizures, you can use benzos. You probably don't want to use dilantin on these. It slows the metabolism. And you certainly don't want to give them physostigmine, the antilirium, because of the side effects. And here you see an R wave with a widened triangle. QRS is wide, and an R and R. So it's the combination of a wide QRS with an R and R that is telling you that they've got a tricyclic overdose. All right, we are through the alphabet. What exists in the last 8 minutes I got here are a bunch of mnemonics. They were put together by Tim Erickson. You all have probably seen Tim Erickson lecture and throw stuff out into the audience. No, I'm not going to do that. But if you like these things, they're useful. This one, for example, I find this little list of odors kind of useful because sometimes they'll give you the odor. So there's some on that one. I like that one. Coins, I use chipes for this, but the radio-opaque items, chloral hydrate, opiate, they also have the cocaine there, iron and other heavy metals, neuroleptic agents, sustained release. Okay? We already talked about the charcoal not useful list. There it is for you. Non-dialyzable drugs, sort of useful, because they're all protein bound. And that's it. Those are the ones that I find the most useful. And so, tox, remember when you're studying tox, you got the 2 pages of antidotes. That's pretty important. The next most important thing is the 6 toxidromes. Because if they're going to give a non-toxicologist a question, it should have a toxidrome. And probably the 3rd most important is mud piles. If they give you the electrolytes, they want you to calculate the anion gap. And I'm a little up. Are you ready to go, my man? Peter Sokolov on his way over. So that's tox. Tox is a great thing to study, and just from this source. Because if you knew the stuff here and kind of went through it, remember, they're not going to ask you super hard tox questions. They're going to be straightforward tox. So this should do it. This should do it. If they ask something harder than this, bungole. That's what I say.